Example of venocapillary and arterial hypertension at the same time is seen in entities such as mitral stenosis. The classic radiographic findings in patients that have isolated or pure mitral stenosis is the presence of a non-enlarged heart in the frontal projection, the presence of left atrial enlargement as manifested by a rounded density seen in the central portion of the heart with a lateral displacement of the upper portion of the pleuroacic-esophageal line, the presence of a third arch in the right heart border, the other two being the shadow of the superior vena cava or ascending aorta superiorly and the right atrium inferiorly. Between the two, a third arch is observed due to the lateral growth of the left atrium. The presence of an enlarged left auricular appendage producing a bulge in the lower portion of the middle third of the left heart border, and the small aortic knob. In addition, we see the prominent hyla and upper lobe pulmonary vasculature if pulmonary hypertension has resulted in patients with mitral stenosis. The lateral view of the chest, as seen to your right, shows increase in the surface contact of the heart with the sternum due to the right ventricular enlargement, the focal displacement of the esophagus due to dorsal enlargement of the left atrium and displacement of the left atrium by an enlarged right ventricle, and we will also see more prominent vessels in the upper zones than in the lower zones. The difference between mitral stenosis and mitral insufficiency is that in the latter, the left ventricle is enlarged and the left atrium is larger than in mitral stenosis. Also, the pulmonary vasculature may be normal in patients with mitral insufficiency, while usually it is abnormal in patients with mitral stenosis. This is a close-up of the right hemithorax of a patient with mitral stenosis and pulmonary hypertension. Note the prominent right hilus, which is due to the enlargement of the right pulmonary artery, and the prominent draining upper lobe pulmonary vein. We also note the narrowing of the lower lobe vessels, and this is typical of what is called flow redistribution. The pulmonary vasculature may be decreased in the periphery of the lungs, suggesting then the presence of pulmonary arterial hypertension. This coronal tomogram confirms the prominence of the hyla and of the upper lobe vessels in patients with mitral stenosis and pulmonary hypertension. Note that the medial vessel is the artery, and lateral to it is the pulmonary vein of the right upper lobe. Note that the prominent hilus, which normally should be concave or flattened outward, becomes convex laterally, and this is because of enlargement of the upper lobe pulmonary veins. This is the pulmonary angiogram of a patient with mitral stenosis and pulmonary hypertension. Note that there is a prominence of the upper lobe vasculature and a relative diminution of blood flow to the lower zones. This asymmetric pulmonary blood flow with prominent upper lobe vasculature is very characteristic of venocapillary hypertension. This can be seen not only in mitral stenosis, but can also be seen in patients with heart failure. It could also be seen in patients with bibasilar emphysema and also patients who have bibasilar pulmonary emboli. This is the venous phase of a patient with mitral stenosis and pulmonary hypertension. Note the early appearance of the upper lobe pulmonary veins and evidence of flow retardation. In the lower zones, we may see arteries at a time when arteries are not visualized in the upper zones, and we may not see veins in the lower zones due to flow retardation. Note that the lower third of the lungs appear relatively oligemic. Small nodules may be seen in patients with mitral stenosis. They are usually associated with either repeated bouts of pulmonary hemorrhage, and these are the small nodules of pulmonary hemosiderosis, which is among the smallest dots or nodules that we can see on radiographs, and the other nodules can calcify and represent pulmonary ossification nodules. The latter can mimic pulmonary granulomas and less likely metastatic disease with calcified metastasis. The pulmonary ossification nodules are usually seen also in patients with severe pulmonary arterial hypertension as secondary to mitral stenosis. In this lateral view of the chest, we see continuous displacement of the esophagus, secondary to intrinsic enlargement of the left atrium, and also dorsal displacement of the left atrium, secondary to right ventricular enlargement. The greater the surface contact of the heart with the sternum, the larger will be the right ventricle. Exception of this rule would be in patients who have increase in the AP diameter of the chest because of pulmonary emphysema, and in those that have narrowed the AP diameter of the chest, in which case we usually see increase in the surface contact of the heart, and not necessarily this is related to right ventricular enlargement. What is of interest in this case is to note calcification that does not project in the center, but below, behind, and to the left of the position of the aortic valve. In other words, if we had a frontal view of the chest, we would see that this calcification is to the left of the midline. This calcification is typical of mitral valvular calcification. One must distinguish between calcification of the valve and calcification of the annulus. The heaviest calcification that produces a ring-like density is in the annulus. The speckled calcification usually is in the valve, and fluoroscopically it moves from back to front, from up down, different from the aortic valve calcification that moves more vertically. So this is classic for mitral stenosis. Also note the enlarged right pulmonary artery producing a prominent hilus and the prominent upper lobe pulmonary vasculature. This is a classic example of the so-called hemi-hilus sign. Note that there is a prominence of the hilar density due to enlargement of the right pulmonary artery. We also note that there are prominent vessels in the upper zones due to blood flow redistribution, and relative narrowing, almost inapparent vessels in the lower zones. And this is because of the flow redistribution due to narrowing of the pulmonary arteries and veins of the lower lobes. This is why the name hemi-hilus, meaning that we only see half of the hilus. We really are seeing the upper half and the lower half, but the upper half is more prominent than the lower half. In patients who have had a resection of the left auricular appendage, the frontal view of the chest mimics precapillary pulmonary hypertension. Note in this case the enlarged pulmonary trunk, but note that below it we do not see an enlarged left auricular appendage. However, there is a faint double density, faint disc like opacity in the central portion of the heart and prominent pulmonary arteries and veins of the upper zones and relative narrowing of vessels in the lower zones. The vascular changes in pulmonary hypertension of a patient with mitral stenosis may take up to 1 year to see significant morphological changes. Following repair of the mitral valve, the abnormal pulmonary vasculature will persist for a period of time. So the estimate of pulmonary hypertension or the levels of elevated pressures in the pulmonary arteries are unreliable in successful post-operative chest rentgenograms. The abnormal vasculature may be seen, and the patient's pulmonary artery pressures may have returned to normal or almost normal.